welcome to Beta Blockers. My name is David Woodruff. I'm the president of Ed for Nurses, where we empower nurses to become extraordinary. Join us online by going to edfornurses.com. That's ED, the number 4, nurses.com. All right, today we're going to talk a little bit here about beta blockers. One of the things that's very helpful for nurses is to understand classifications of medications. More important than understanding the individual medications themselves is understanding the classification. Therefore, you can apply that information to any medication in that classification, and you know what's happening with your patient. So let's take a look here at beta blockers. First of all, to cover some of the different beta blockers that are commonly in use: carvedilol, labetalol, propranolol, sotalol, timolol, esmolol, and metoprolol. Those are all common beta blockers. One thing you may have noticed already about the names of these medications is that they all end in OL. This is one of the things that the FDA is trying to do. They're trying to get all of our medications to have a common prefix or a common suffix. Therefore, everybody would know right off the bat, even if there's a brand new beta blocker that just came out on the market, everybody would know what it is because it ends in OL. So that's one way to make it easier for us to be able to identify which medications are our beta blockers and which ones aren't. All right, so what do beta blockers do? Well, don't make it hard. Beta blockers block beta. So beta blockers are blocking beta. Well, what is beta? Beta is part of the sympathetic nervous system. Maybe you learned about this at some point in time in your career, the alpha and the beta adrenergic receptors in the body. Okay, those are the two different components there. So let's take a look at what's happening to cause beta reception in the body that would cause a patient to need a beta blocker. Well, first of all, understand that whenever your patient has a low cardiac output state, there's going to be some compensation that occurs in the body. There's 3 different mechanisms that occur whenever cardiac output is low. Now, cardiac output could be low because the patient had a heart attack. It could be low because the patient is hypovolemic. It could be low because your patient is septic and it's septic shock. Any condition that causes a low cardiac output state is going to cause these compensatory mechanisms. The first of which is the sympathetic nervous system. Now, if the cardiac output is low, the sympathetic nervous system kicks in and tells the heart to beat harder and faster. See, that kind of makes sense. It would work, and it would increase the patient's heart rate and blood pressure if the patient had a low cardiac output state. The second condition would be the renin-angiotensin system, which kicks in, causing vasoconstriction to maintain our blood pressure. Thirdly, we have the aldosterone system, which kicks in to tell the kidneys to hang on to more fluid so that we retain more fluid. Now, one of the things that you may have noticed already is that these compensatory mechanisms all help in hypovolemia. But they don't help if your patient has a cardiac problem. So if your patient has a heart problem and these things are kicking in, they're actually going to be counterproductive rather than being productive and helpful for your patient. So, for example, you have a patient who is walking across the desert, does not want to carry a canteen with him, and he's dehydrating. Well, these compensatory mechanisms help. The sympathetic nervous system kicks in, telling the heart to beat harder and faster. That'll increase our cardiac output. The renin-angiotensin system kicks in, causing vasoconstriction. Well, that's going to increase blood pressure. And lastly, the aldosterone system kicks in, and it's going to tell the kidneys to hang on to more fluid. That's going to be helpful when we're dehydrated. But look what happens when your patient has a cardiac problem. So my patient currently is having chest pain, shortness of breath, diaphoresis. My patient's having an MI. I give this patient the sympathetic nervous system stimulation, and I'm telling the heart to beat harder and faster. Okay, well, that's not going to be helpful. That's probably going to harm the patient more than it helps. Secondly, the renin-angiotensin system kicks in, telling the vasculature to constrict, and we get vasoconstriction, and that's going to cause more resistance to cardiac pumping. That's not going to help. Lastly, the aldosterone system kicks in, telling the kidneys to hang on to more fluid. Well, this patient doesn't need more fluid. They can't pump the fluid they already have. So these compensatory mechanisms will actually make your patient worse. Now, what happens in our patients is that they have the heart problem, which causes those compensatory mechanisms. Those compensatory mechanisms then cause decompensation, and that decompensation then leads to heart failure. So this is how your patient ends up developing heart failure. Now, you may have noticed that heart failure tends to be a progressive disease and tends to get worse in many of our patients. The reason for this is because that continuous compensation, is continuously making the patient worse. So those compensatory mechanisms of the sympathetic nervous system, the renin-angiotensin system, and the aldosterone system are making the heart work harder, which makes the heart failure worse. Therefore, in order to try to prevent this decompensation and to prevent the worsening of heart failure, we want to block those compensatory mechanisms. Now, the sympathetic nervous system is going to cause three main things to occur in your patient's body. It's going to increase the cardiac output by increasing the blood pressure and the heart rate. It's also going to cause bronchodilation, and it's going to increase glucose release from the liver. So the liver kicks in, it does its little glyconeogenesis thing and creates more glucose, increasing the glucose level. Now, keep in mind that these compensatory mechanisms here of the sympathetic nervous system are designed to be part of the fight or flight response. Fight or flight. Now, if you have the fight or flight response activated, that means you are going to need to run or you're going to need to fight. So you need to get more glucose and oxygen to the muscles so that you can fight or flight. That's why we get the bronchodilation and the increase in glucose. Now, when we give a patient a beta blocker, we are blocking the sympathetic nervous system. Therefore, we're not only decreasing the blood pressure and the heart rate, the things we commonly associate with beta blockers, but we also potentially could be causing bronchoconstriction, which might cause problems in your asthmatic or COPD patient, although some recent research has shown that beta blockers are safe and effective in our COPD patients. But still, we want to use caution in that asthmatic. Lastly, because the sympathetic nervous system increases the amount of glucose that's being released, if we block the sympathetic nervous system, it's possible that the glucose level could get too low, and that would be especially true in your diabetic patient who is taking some anti-diabetic medication. So the effects of beta blockers are going to be, they're going to decrease our heart rate, cardiac output, and blood pressure. Therefore, we need to monitor and observe those parameters. So when we're giving our patient beta blockers, watch the blood pressure and watch the cardiac output and the heart rate. Typically, we're going to use as parameters a systolic pressure less than 100 and a heart rate less than 60. So if the systolic pressure is less than 100 or the heart rate's less than 60, we're going to hold the beta blocker. Now, obviously, there's many situations in which that may not be true. For example, if you have a cardiac patient in a cardiac unit, you often give beta blockers to those patients, even though their blood pressure is maybe in the 90s, even as low as 90 or 88. I've seen patients get beta blockers. Now, they need it because it blocks the decompensation caused by their heart failure. Now, the second mechanism then would be that beta blockers can decrease blood glucose. So watch and use caution in diabetics. If you're starting a new beta blocker in your diabetic patient, use caution. Just be careful because it could drop that blood glucose lower than you expected. Lastly, we have bronchospasm that could happen in our asthmatics. Use some caution in that asthmatic patient to try to avoid that complication. Some adverse effects that happen with beta blockers include nausea and vomiting. Bronchospasm could occur, as we mentioned before, by blocking that sympathetic nervous system bronchodilation that's occurring, and dyspnea. Cold extremities, we can get an exacerbation of Raynaud's that could be happening in our patient because of the beta blocker. Bradycardia, hypotension, heart failure, those are all complications. Now, wait a minute, you may say, hang on now here. Heart failure can be an adverse effect, but we're using the medication to treat heart failure. Okay, we are going to use this medication to treat heart failure, but in some patients, if they get beta blockers, it can decrease their cardiac output significantly enough that the patient ends up developing heart failure or maybe gets an exacerbation of the heart failure. So obviously, we're going to want to watch that patient's vital signs and watch that patient's cardiac output to make sure that that's not becoming an issue for the patient. Fatigue, dizziness, orthostatic hypotension. When you first start giving these medications to your patient, make sure that you are getting them up slowly so that we don't run into the orthostatic hypotension issue. Remember that your geriatric population is often at risk for orthostatic hypotension, and we add a vasoactive medication to the mix can really cause problems for that patient. Beta blockers are metabolized through the liver. Therefore, a lot of other medications could either interfere with our beta blocker or be interfered by our beta blocker. So there's decreased metabolism of the liver of the beta blocker when the patient is taking one of these other medications. If your patient's on amiodarone and also getting a beta blocker, we need to use some caution to make sure that the effect of the beta blocker doesn't increase. increased metabolism that occurs with barbiturates and rifampicin. Using caution with patients who are diabetic and taking insulin because that can lead to hypoglycemia. Using caution with your asthmatics because beta blockers could cause the patient to have bronchoconstriction. ACE inhibitors and calcium channel blockers, we can have an additive effect where the patient can end up with bradycardia and hypotension. Also watch, in your patients taking antiarrhythmics, we can end up getting severe bradycardia or asystole because we've blocked them down a little too much. Okay, again, if you understand what's going on with beta blockers as a classification of medication, it can certainly help you to be able to provide better care for your patients and identify when that new beta blocker that you have to give to that patient comes out. You can say, okay, well, I know a little bit about it because I know about beta blockers. Thanks for joining me for beta blockers. Come join us for more videos at YouTube/EdForNurses or come to edfornurses.com. Thank you for joining me. My name is David Woodruff. Until next time. Bye now.